we're going to be talking about motivational interviewing, stages of change, cognitive behavioral therapy, harm reduction, and boundaries tonight. Can we go to the next slide? So the module overview, we're going to be talking about motivational interviewing, which is a collaborative approach to addressing ambivalence, stages of change, which there are 5 stages, and a tailored interventions for each of them. And then we'll talk about cognitive behavioral therapy, known as CBT, behavior emotional connections, harm reduction, meeting clients where they are, balancing safety and autonomy, and then therapeutic boundaries, maintaining effective relationships while helping our clients. Next slide. Next slide. So motivational interviewing was developed by William Miller and Stephen Rolnick, and it really addresses ambivalence and about change. And it's an interviewing skill that is collaborative, person-centered communication style, and it's designed to strengthen a person's own motivation and commitment to change. And what they're doing by resolving a person's ambivalence is they're looking at the state of feeling about behavior, their state of feeling in 2 ways about behavior, and they're trying to elicit the person's own reason for change. So they're trying to, they look at somebody with substance use disorder and say, there's ambivalence in this, and then they want to see what they can do to move them away from that. So there's some core elements in motivational interviewing. So they try to use what they call the spirit of motivational interviewing. So there's partnership, acceptance, compassion, and evocation. And partnership is working together as equals rather than the expert, like the therapist is the expert and the client is the patient. They don't look at it that way. They look at it as a partnership. And that in that partnership, they develop a dynamic between them so that they can work collaboratively. And then there's acceptance and there's respect of the individual's autonomy, and the client has this inherent worth. So they don't look at them as, oh, you're a substance user, you've got the problem, and I've got the solution. So they have this respect for the client. And then there's compassion. They actually actively promote the other's welfare. And so in this partnership, they have to have this compassion. And then evocation. They try to get ideas for the solution from the client. So it's not just where the doctor or the counselor is telling the client, you should do this, you should do that. So there's this collaboration between the 2 of them. And then there's 4 basic interaction techniques that they use. There's engaging in order to establish that trusting relationship. There's focusing to identify a specific goal or direction for the conversation. And then there's the evoking that I talked about already, where they try to find the voice or the why in the problem that's happening. And then there's planning, where they formulate a concrete, actionable plan on how they're going to get to that motivation so that the motivation stays high. So one of the central rules of motivational interviewing is to avoid what's called the right reflex, which there's this urge on the part of providers to fix people. We go to school, we learn all this stuff, and we think that because we learn all this stuff, we have answers in textbooks. And we might have the answers of if you have a high blood sugar, oh, we know the answer is to give you insulin. Or if you have asthma, we know the answer is an inhaler. But in this, it's different. And so we have to avoid this writing reflex of thinking that we have the answer to everything. And so we can't think that we can fix everybody. So in this case, we try to avoid unsolicited advice, avoid arguing with people to get our point across. And we want to stay in that realm that I talked about earlier of a respect and mutual collaboration and getting and letting the client also come up with some of the solutions to what's happening in their life. So, motivational interviewing was developed specifically for substance use disorder, but it's now widely used in a lot of different areas. It's used in um, mental health disorders, it's used in behavioral change, it's used for weight loss, it's used for smoking cessation, it's used for physical activity, it's used in a lot of different things. So, what we are hoping is that you use reflective listening to validate the client's perspective. You want to make sure that the client recognizes the gap between their behavior and the goals that they want and the values that they want, the change that they want, where they want to see themselves at some point in the future. So that's sort of like a little, summary of the core principles of motivational interviewing. Next slide. So you want to also use open-ended questions. So you say, tell me about the problem you're having. Um, do you use drugs daily? You don't want to use closed-ended questions. You also want to use affirmations to help them see their strengths. So, you can do it. I know you can. And you want to use positive values that you know that the person has. The other thing is for example, if a person, let's say they had stopped drinking, let's use that they were an alcoholic and they were drinking and they used to black out or they used to drink, on a daily basis and they have stopped. And they come in one day and they say, you know what? I went out Saturday with some friends and everybody was drinking and I drank a beer, you know. And then you look at them and you would say, wow, you know, think about this. You had one beer last week or 2 weeks ago, what would you have had? You would have had 10. And so you show that even though they had a slip, their slip was one beer and not 10 or 15 or 20. So you find a way to find something. So you listen to them, you listen reflectively, but you find a way to show them that their slip was not as bad as their slips were in the past. So there's a reflective listening and you tell them back what you heard, but you also find a way to give them an affirmation and say, this was not as bad as it was 2 weeks ago, 3 weeks ago, 4 weeks ago. So there's that kind of interaction that you have with them as well in this motivational type of setting where you're trying to show them that they have the strength in them to recover and move forward. Next slide. Then there's the stages of change. The stages of change is another behavioral model. And this one looks at identifying where the patient is in their motivational change and then matching your intervention to their stage. So we start with pre-contemplation. And in pre-contemplation, the patient or the client is not aware that they have an issue or a problem. So they are not trying to change. If you went to them and said, your substance use or your cigarette smoking or whatever the behavior is problematic, they look at you like, what? They're unaware. They're not trying to change. And then in contemplation, they're beginning to think about that their behavior is somehow problematic, but they're not ready to make any changes. They're thinking about it, they're contemplating, but they're not ready to make a change. In preparation, they have become ready, they're thinking about it, and they're beginning to make a commitment to make a change. They're beginning to make a plan. They may have decreased, if they're a smoker, they may have decreased a few cigarettes, but they haven't stopped. They're just thinking about it. And in action, the action stage, they're actively making changes in their behavior that requires some support maybe some monitoring, maybe some assistance, but they're actively making changes in their behavior. And then maintenance is sustained change. This is when they are so motivated that they have stopped the behavior that they've been doing and they are actively trying to uh, stay on that behavior. So whether it's stopping alcohol, stopping drugs, stopping cigarettes, stopping eating, whatever it is, eating, overeating, whatever it is, and they are continuing trying to stay on that path. And then there is another one that's relapse that some people look at one of the as the sixth stage, where people can relapse and then they can go back into any one of these stages. So it's a cyclical cycle model. Go on to the next slide. So we have to tailor the intervention by the stage. So when somebody's in pre-contemplation, you can't go to them and say, wow, so you don't know you have a problem? Your smoking is disruptive. It's going to kill you. Look at these pictures. Like those commercials they used to put on TV where they show the picture of the person's lung and the person dying or the hole in the throat. That's not going to do anything because they're not ready. They're not ready to hear that message. They're not ready to see that message. So what you have to do when somebody's in pre-contemplation is you have to build trust. You have to try to explore their ambivalence and you have to try to find a way to not push them away from you so that you can educate them and send a message to them that's appropriate to that level. So you want at that level to be able to give them education around things. They may want to ask you questions, and then you want to answer the questions that they give you. But you don't want to scare them away because they won't come back to you. So you show them scary pictures, scary commercials, scary whatever, and you're going to lose them. So you have to build trust, explore their ambivalence, and avoid pushing them away from change. Because if you do, you lose them for a longer period of time. And research has shown that you lose people during pre-contemplation if you send the wrong messages. Then during contemplation, they're having this decision. They're in this balance where they're thinking about changing, they're making some changes, they're thinking about it. And so they're coming up with pros and cons. And so this is a time where our message can be directed towards helping people with that pros and cons list. You can help people by telling them the pros and cons to the behavior that they're doing. So if it's cigarette smoking or if it's this model was actually developed for cigarette smoking by Clementi and Di Clementi and Prosciutto. And you can actually give them information. So you can tell them the pros and cons. You can let them know how cigarette smoking is bad for your health. You can tell them how a decrease in cigarette will help. You can give them all this information and you can help them make a decision whether or not to stop the behavior that they're doing with factual information. So you can do that in contemplation because they're ready for that message in contemplation. You can't do that in pre-contemplation, but you can do it in contemplation. And so you can tailor your message directly in that manner. Then when the person is in preparation, then they're planning. They're thinking about exactly how they're going to stop. They're planning. And so you can tailor a message, you can give them information. Oh, did you know if you call 311, they will give you free uh, nicotine patches? Or if you go down to the Department of Health, you can get, uh, uh, you know, uh, clean needles, or you can give them specific information around the behavior that they're trying to stop. And so you can give them concrete planning, goal setting, and
Hello?
support uh, information for them. So you can give them specific information depending on it. If it's an eating disorder, you can direct them. You can direct them to AA, you can direct them to NA, you can direct them to OA. You can give them specific information during that planning while they're preparing. So then we go to action. Action is behavioral. Can we stay on that slide? Stay right here. Yeah. Action is behavioral. And so you can now begin to give them coping skills. You can give them specific behavioral techniques. You can work with them. You can refer them to therapy. You can refer them to specific groups. You can give them rewards, programs, and progress. You can monitor them and help them in that way. And then you can also, in terms of maintenance, when they move into the maintenance phase, you can do things, if you know things that lead to relapse, you can do relapse prevention. You can help identify triggers, people, places, and things. You can help them in all those kinds of ways to help. You can help them strengthen a network, let them know, you know, um, that support groups are there and so forth and so on to help them make sure that they don't relapse. Next slide. So cognitive behavioral therapy. Cognitive behavioral therapy is also a specific type of talk therapy. It's structured, it's goal-oriented, and it's a time-limited therapy. Typically, it's scheduled for like 5 to 20 groups or individual sessions that people go to. And it's geared towards helping people change their pattern of thinking. People have negative thoughts and behaviors, and they want to change that so that you can think in a different way. So, what they do is you work with the therapist, and it's focused on present, practical, evidence based tools to manage conditions such as depression, anxiety, PTSD, chronic pain, and substance abuse disorder, and alcoholism, stuff like that. And it focuses on interconnectedness. You want to be present focused. It focuses on skill building and collaboration. And it works on helping to cognitively restructure behavior activation and helps on conditioning the person so that you can just reprocess the brain so that if you had these negative thoughts about yourself, you can change those thoughts to positive thinking. Um, so one example is I had a friend who does CBT, and she told me that she used to always think she has OCD, and she was going to cognitive behavioral therapy. And she always used to think that because she had this excessive washing of her hands, that she was a bad person. And she also has depression. And she learned in cognitive behavioral therapy that that these two things of having depression and having OCD, they could exist at the same time in the present, and that she could still be a good person by changing the way she saw the world and the way she thought. And she had to think about things differently. That what she had was a condition that some people that everybody didn't wash their hands as much as she did, but there was nothing wrong with her washing her hands so many times. And that she just had to think about, okay, I just wash my hands more than other people. So that's okay. And she would just, rather than think, the therapist would tell her every time you think it's bad for me to wash my hands, she would tell herself it's okay for me to wash my hands. And she would and they just told her you just have to keep saying that over and over. And in repeating that, she said that she began to think less and less that she was a bad person. And by thinking less and less that she was a bad person, she began to have less depressive symptoms. So the two things went hand in hand because it was the thought processes that led to the depression. So when she started to train her brain to stop saying the negative thinking, it impacted her depression. And so she was able to train her brain to stop making the association that washing her hands made her a bad person. And then, therefore, the depressive symptoms alleviated. And when the depressive symptoms alleviated, she ended up stop washing her hands as often as well. So one fed into the other, and she decreased. She still washes her hands a lot, but she didn't wash them as often. So the two things went hand in hand. Is that an example that kind of gives you an idea of how these things work? So it works by training, and it was a forceful change in her thought process where she had to forcefully change her thinking, and that forceful change in thinking impacted her depression, and the depression impacted her OCD. And now she doesn't have to do that as often because the thinking changed. And so she went in and was able to interrupt negative thinking. And so that's how cognitive behavioral therapy works. So that's just like one example of how that works. Next slide. So it's the same thing with cravings. So if you have cravings, you identify the craving, you develop a coping strategy for the craving. So I crave crack. What is it? How do you crave it? They would work with you to identify exactly what situation are you in, because it's people, places, and things. So who are the people that you're associated with? Where's the places? What are the things that lead to those cravings? Then you would come up with a coping strategy so that you could manage the automatic thoughts that come with it and change those thoughts. And in changing those thoughts, you can decrease the cravings. And that is a way in which CBT would work. You would find your high risk situation and anticipate the challenges and role play. So you role play with and and figure out how would you know how would you interact? What would you do if you're going out and you run into somebody and they say, "Hey, let's go hang out on Friday night. Let's go and do," and you role play in advance so that you would know what you would say in this scenario. What would you do in this scenario? And so you'll have your clients role play so that they can build confidence and know how they would interact and what they would say and how they would act in this so that they can have these responses so that they would be ready. Um, they would have to understand what their triggers are so that when the trigger occurs, they understand it and they're not as vulnerable to the trigger. And they learn to be assertive and learn how to act in a appropriate way in social situations, and they learn to regulate their emotions, and they learn how to problem solve. And so they do that in these settings, either in individual or in group. So CBT many times is in group settings, and so they work with other people who have the same issues as they do, and they do these role playings and they build their confidence and they learn how to socially interact with one another. Okay, next slide. Does anyone have any questions, by the way? Okay. All right. So harm reduction. Harm reduction has been around for many, many years, and it is really focused on helping people minimize the harm that they encounter in the behaviors that they are engaged in. So needle exchange, um, condom use, um, having access to supportive services so that we're accepting people where they are, how they come, with the issues that they're having, so that we minimize the harm that is happening. We're giving people the autonomy and the respect, the choices that they're making, their self-determination. They are the masters of their lives. We treat all people with dignity. We try to avoid judgment and stigma, and we give value to everyone, and everyone deserves health despite it doesn't matter what, how they come to us. So whether they come to us using drugs, using, multiple sex partners, it doesn't matter. They come as they come. And so the core principles of harm reduction is um, is not to have is for the client not to have a negative health consequence um, during their use. And then when they're ready to give up, that's when where the healthcare team is there. So the healthcare team is there while they're using, the healthcare team is there if they stop using. And so that's the premise of harm reduction. Next slide. So you have needle exchange programs, and that helps prevent bloodborne infections by giving access to clean needles. We have overdose prevention with naltrexone, and that helps stop overdoses by having access to Narcan so that people don't die from overdoses. The house first model is wraparound services so that people can get services in homes. Medication assisted treatment, methadone, buprenorphine, naltrexone. We know that these things work. Methadone works, buprenorphine works. Now every doctor's office can provide that. Naltrexone works. All of these drugs work as harm reduction and making it easily available. So doctors like Dr. Griffin, he can prescribe buprenorphine and naltrexone, and these drugs work to help with opioid addiction. And so having them available and without judgment, the patient comes in, they get assessed, and the doctor determines what they need. Methadone is the one that most patients have to get in a methadone maintenance clinic. But the other drugs are available now at doctors' offices without restriction in terms of the number of patients that a doctor can have. So um, that's made it um, easier for patients to get access to these medications. Peer support. There's more and more peer specialists, recovery coach, and community like sober houses and places for people to go. Uh, um, Detoxes and IOP programs, the outpatient um, recovery centers and stuff like that. So there's more and more places for people to be able to get uh, care, detox centers, and stuff like that. So there's more and more places for people to be able to get help, but to be able to get um, help regardless of where they are in terms of whether they're ready to stop. There's very few. I mean, these are the models. These are the models that are there. Does anybody have any questions about these? All right, next slide. All right, boundaries. Now, this is where it's really, really important um, for us with boundaries. Um, we have to remember that we're there to help the clients. It's not a friendship. Um, you have to have clear role with your clients. You have to be able to help your client. It's a very tricky relationship as CASAC and counselors and your client because you get to know a lot about your clients. There are times when you want to reveal a little bit more about yourself. There are times when it's appropriate, there's times when it's not. But even if you do disclose a little bit more about yourself, you still are the professional and they are the client. And that relationship has to always stay professional. So there has to be the authority on your side. And so, I think that you have to be able to make sure that you're always the ultimate professional and that you don't cross boundaries with clients because there are some clients that will take advantage of that if you are not careful. And so you have to be very, very careful in your role and your expectation with clients. Um, and so that is something that you have to be aware of. Uh, the counselor has the authority, and there is always the potential of exploitation in both directions. And you have to be very careful. Um, I don't know, Michelle, I always feel like I call on you in these situations, but you know what I'm talking about, right?
I definitely do. I have trouble with it because I tend to spill my guts to like everyone, and it's really hard to keep that line and not divulge too much. And I have to say I have done that. I've say, and I'm like, oh, I can't believe I said that, and it's a learning process for me. I mean, some people are not very forthcoming with their emotions and situations that are happening, but unfortunately, I am. So it's difficult. It's you have to be super aware, super aware. And the harm reduction is also an issue for me because I've been abstinent for 40 years. And when I became a recovery coach, and we learned this stuff. I have to really like just get my thinking open, and that no matter what you want to do, that's okay as long as we're reducing the harm. It's really hard when you sort of grown up in an abstinent program to embrace MAT and harm reduction, but that's what you have to do. It's like it's just another way of thinking, it's another way of recovering, it's another way of getting healthy. So I just wanted to say that because I don't know how many people are, in a program or doing that, but it's really hard when you are in an abstinence-based program to embrace this. But that is what over time I have done, and just by opening my mind and opening my heart, really, it's like, well, you are trying, you're trying. And
Right,
so, I just wanted to say that.
right, right, right. And I wanted to point out in terms of boundaries as well, um, that you have to be careful with things like uh, taking gifts, borrowing money, lending money, personal disclosures, socializing with your clients, you know, um, you know, and it could happen that you run into somebody at a meeting that's unavoidable, but you have to be very careful with these things in particular that is on the slide. That those things are kept, and obviously romantic relationships are unethical and illegal. Um, so I wanted to point that out as well. Next slide. Okay. All right. So there are written policies around contact. Depending on where you work, there might be a policy specific. Some jobs, I know that, for example, at my office, gift giving was a no-no. But if somebody gave you a gift, if it was the value was less than $15, that was okay as long as it was disclosed, so that you had to tell them at your office that a client gave you a gift, and if the value was deemed to be less than $15, then it was okay. Otherwise, you were not allowed to accept it. So it's stuff like that. Uh, when you're talking with your clients, you also always should use formal language. You know, when writing text or other, emails and stuff like that, the same thing. You should also use formal language, and you want to minimize personal information, and your availability should be consistent and should be within the working a day and the working hours. And you also always want to tell everything to a supervisor or a peer consultant so that you always have somebody that you're bouncing things off of. Uh, and then you want to be careful with counter transference and be aware. Everybody knows what that is, right? Where you may have feelings um, towards a client. So just monitor and be aware of that. And then be aware of any personal vulnerabilities that you may have in this field. Like some of us are very, very kind. Some of us are very gullible. And we know this. We know it in our personality. Like, for example, I'm the kind of person that will give the shirt off my back to anybody at any time, all the time. So I know that I have to be very careful, because if I'm not careful, I give everything away. So I know this about myself. So I have a rule, you know, don't I don't give anything to any client because if I do, I get myself into trouble. So you have to just be careful like that. Yes, Nigel. I see a hand up. Nigel, is that you with the hand up? All right. I guess not. All right. So anybody else have questions? Okay, next slide. Is that the last slide? Is that the last slide?
Countertransference is like, hey, saying, hey, appealing to your provider or to your counselor and saying, to a sense to where like they're your parent, but they're really not. Like they're going to be people who we might identify with,
Right.
people who might feel like we've been in their shoes before, but we don't want to let people who are in that situation appeal to us in that way because they might use that for special privileges that other people who we're serving might not have the same privileges. So then they'll say, oh, and then it kind of makes you put yourself in like a parent role. That's countertransference, saying like pressuring you into like helping the person because you feel, you kind of feel like, you can change their lives magically by just helping them.
Right. Exactly. So is there another slide, Nigel? Or is that the last one? Okay. All right. So the key takeaways, motivational interviewing addresses the ambivalence through empathy, discrepancy, and rolling with resistance and supporting self-efficacy and the stages of change. It's a framework that has an intervention toward client readiness, and it's not linear, so that you can go into any piece of the stages of change. A person can come in at any point in that stages of change. And CBT identifies thought, emotion, behavioral connections, and it's practical for craving management and skill building. And harm reduction is client autonomy while reducing negative health and social consequences. And then with professional boundaries, we protect both the client and the counselors, and it's essential for ethical practice. So I'd like to open it up now to discussion about the different counseling styles or any thing that you guys have seen in your out in, in your experiences or questions that you may have. You can unmute and jump in. Apostle Davis?
No question. I'm just listening. I'm learning. Your explanation and the way you presented tonight, it was it was fantastic. You made it very understandable.
Thank you.
Do's and the don'ts. And I think if we take what you have said, we can be effective counselors, especially when it comes to the avoidances.
Uh, and what about any any personal experience that you've had with any of this?
Well, it's kind of like every day. I mean, when you're dealing with people, especially as a minister, you try to do the very same things you're saying. You don't want to get too personal. You don't want to be too authoritative neither, because you want to be able to draw the person in and offer the help that you do have. So that's like that go from client to client, person to person. you know. And I think if we practice these things in any relationship, be it with all the points of being careful, we'll do ourselves a great thing as far as development. We can practice these things all the time because right in our homes with our own children, and if you're married or whoever you're with, your significant other, there's a lot of things that we do where we let our guard down when we should still keep it up.
Right, right, right. That's true. Yeah. hmm Anybody else want to jump in? Give your thoughts?
Hello, can you
Yeah.
hear me? Can you hear me?
Yes, we can.
Right. For me, the knowledge was always very important. Knowledge is always important, but me working in the professional field for a number of years, I'm very much familiar with all of this in terms of boundaries and stay professional in your job. Because basically what I really learned is just that this is just like it just brought me more to understand that you're going to always encounter these things, and so you have to always make sure you stay on top of the game, because these people will do everything in their power to see what you're really made up of, and so you have to always make sure you maintain your integrity. In correctional that I've worked over the period of time that I've been working there, I've encountered so much of this kind of behavior and attitude. And sometimes they will like you and sometimes they don't like you. And they're going to always say all manner of evil about you when you decide that you're not going to allow them to take advantage of you. Your kindness and all of that. I mean, I give, but I know when and how and when to say no.
Right.
I always maintain that. And the job that I've done, it taught me a lot. It does. Because working correctional, it taught you a lot.
Right.
Yeah. So this is all more everything here that you're all teaching. I got that in the correctional services training in Jamaica over the years. So I'm very much familiar with it.
Good.
But I'm glad for more. I'm glad for more teaching.
Good.
Thank you so much.
Okay. Anybody else?
I appreciate it.
Nigel put questions in the chat for you guys to answer also to see how much you retained. So you should, based on this lecture, you should be able to answer those questions.
Yeah, do we want to go through them now and then we can kind of like talk through them? Once we finish, when we finish at the end?
Okay, we could do that.
Okay.
Anybody else have any comments
About what? Just
about,
generally?
yeah, the lecture? Anybody else? Harriet, Jasmine? Any comments?
I just have something to say. If if somebody is writing down like the notes and stuff, and it's a little bit going too fast because I'm trying to write down notes as I go along, and it's like everything is next. Is there a way that you can send it to everybody's email that uh try to that is writing down the notes and stuff like that, and they can get it from there? That would be better
You're talking
because
about lecture?
I'm going to release a link with all the recordings and all the slides. That it's going to be like a link you just go into and have everything there. I'm gonna put it out next week.
okay. Thank you.
You also have a learner's manual. Did you all get that manual? Okay, Nigel, they're saying no, that they didn't get it.
We got it. Everyone, just check the email. Check the email. Just go in your Gmail or whatever email you have, and type in KSAC Learner Manual. It was with the first Zoom link. I put it right in there. So just go in there. Anyone who hasn't have it after checking it, I advise you do it now. Send me a message. I'll make sure you get it. Okay.
And that manual has a summary of everything.
And also, it's going to be on the link I'm going to share next week. It's going to be like a thing you go in every week. You'll see the Zoom recordings. You're going to see the slides. Okay.
Right. It has a summary of every lecture, so that you have, so that you don't feel the need to constantly taking notes. It's a manual that tells you everything that is being presented. It's called KSAC's Learner's Manual.
I remember when I have something to say. I remember when I first discovered, I've been always inquiring about this training, and I happened to ask couple of persons about the training, and they would tell me off and that the training, you really have to be an addict. You have to be a part of the addiction thing, like you have to be a part of drug substance abuse. I said, really? This thing bothered this over 2 years. Everybody I asked about this case, Zach. Are you a substance abuse person? I said, no. Don't tell me that they don't take anybody that is clean to do the training. So when I come in contact, getting to know Mr. Ishmael, Dr. Ishmael, he is the one who will let me know that no, you don't really have to be a substance. You don't have to take drugs. Because I've been hearing this from I came in this country. And this program is just a part of what with my background training. And, because a lot of that has been going on in the prison service, right? So when I came to live in here, I started to inquire about this program. And to my knowledge, everybody keep telling me, but you have to be a substance abuse person. I said, really?
No,
So
that's not true.
when I bring it to him, his attention, he said to me, oh my God, that's a lie. You can't come in. I never do any form of drug, never smoke, never drink, nothing. So you guys don't have I don't have any part in this field because I'm a clean person. So Dr. Ishmael was the one who tell me, no, you can't do the trade. You don't have to be.
So we don't use that terminology because it's judgmental to say because you're a clean person,
Yeah, I had a hard time getting to one of the programs.
Yeah. You try
And
to use that terminology, Steve. You try not to use that terminology,
what a
clean person, or because that's judgmental.
okay, clean, right? A clean. Sorry, thanks. Sorry about that. So you have no space for a clean person? And they said he's the one who brought it to my attention when I opened up this to him. He said, no, oh my God, for 2 years they keep telling me that. I said, you're crazy. And I didn't believe it, but I just couldn't find anybody to really enforce something to me or let me know exactly what's going on. Because I would have, and then I learned after the fact that they had a class at Mega Evans, and I went there on my own and do my inquiry, and they let me know that no, you can come in and start it. You don't have to be you don't have to be a person that abuse it. Because
Yeah.
I went and I told them exactly what I heard, and they said, no, that's not true.
Word abused either. They don't use that.
What's the term to use, Miss?
Substance use disorder.
Okay, substance use disorder. I'm sorry. No harm. I'm learning everything different here. Alrighty, thank you guys.
So let's move to our Q&A. Let's go through our Q&A real quick. Let's go to number 1. What is motivational interviewing? Does anyone want to volunteer? Go ahead,
It's
Michelle.
B. A collaborative approach used to address ambivalence about change.
Thank you.
That's correct. That is the definition. Let's go to the next question. Who developed, it should be organized a little bit better. So just disregard the numbers, just go like number 1 and then A, B, C, and D is clearly labeled. So really 6 is actually 2. So the next question, just listen to me, we'll go through it together. Number 2 is, who developed motivational interviewing? Does anyone want to go?
I said it in the lecture.
This is all based on the lecture.
I think I missed out the first one, the first 2 topics.
So what's the
I missed out 2 topics.
Yeah, some people may have came like later. So I'll answer it.
came
The
late.
answer is C, which is
I don't know.
what's the name? C is what name?
William Miller and Stephen Rolnick.
Right.
Okay. So they developed that model. Let's go to the next one. Next question is, wait a minute. 1, 2, 3, 4. Okay, what is the main issue MI is designed to work with? I kind of just, it's easier for me to read it from my phone than it is in chat. Put it there. So the answer is ambivalence about change. Okay, the main issue is designed to work with. So it's helping us model people who are, battling this addiction to adjust their thought process and their behaviors in order to, not fall back into those stages that would be a cycle of abuse. So next question.
I'm sorry, Nigel. Where did you see that response? Because I think I'm not following properly. Because when I see what is the main issue MI is designed to work with, then I see multiple
which
questions
letter?
after.
Yeah, let me pick, because it's like the chat didn't read it right. So let me put them in the chat again.
Okay.
So everyone can see it. For some reason, I wasn't able to put it in. Hold on, let me see right here. Yeah, so instead of it coming out like that, it should be, yeah, that's what it is. It's like putting the bullet points.
Okay.
1 second. It was just a technical error. Let me just delete that. It's gonna take a while. Just to
Okay, I can just follow along,
yeah,
but I was trying to see what the choices were, and then I noticed that it were just multiple questions.
You know what? I'll read them out. I'll read them all out. I'll read out the Q&A. I'll read it out to you. So let's go to the next question, which is number 4. What does express empathy mean in MI? Is it A, agreeing with everything the client says? Is it B, reflective listening and validating? Is it C, telling the client what to do, or is it D, avoiding emotions? What does express empathy mean in MI? Agreeing with everything the client says, reflective listening and validating, the client's perspective without judgment, telling the client what to do, or D, avoiding emotions.
What if it's C?
So express empathy. Express empathy. That is incorrect, Steve. It isn't telling. Expressing empathy, the best way you can express empathy when someone's going through a crisis like that is to do what? We have,
I think it was B. Was it B? Reflective.
yes, yes. So you just
Reflect.
listen. You just listen. You have 2 ears, 1 mouth for a reason. So just how we in our, if whoever was here during the Oasis trainings, there were some modules that were kind of talking about this example where you just reply with, so how does that make you feel?
Right.
Just that's the most thing you're going to tell them. It's just like reflective questioning, mostly just listening and validating, and saying, yeah, I agree, I understand, and just maybe give suggestions to help them model their behavior better. So let's go to the next question. So the answer was B, reflective listening and validating the client's perspective without judgment. Number 5, what does develop discrepancy mean? Does anyone want to just answer? This is open-ended, no right or wrong answers. What does develop discrepancy mean? When someone says, I have a discrepancy, what does that mean? Is that a good thing or a bad thing? If someone has a discrepancy with their treatment or their progress in recovery, is that a good or bad thing? What's your role in that as a counselor, as a CASAC, as a chaplain? These are thought-provoking questions. So I
I
would
missed
say
a few sessions, but I'm just gonna try to try to jump in because I have been a nurse for
we have
about
Sharice
30
here.
years.
We have Sharice
So I
here.
might
She's
know the
phenomenal.
answer.
She is
Um,
amazing, and we're happy to have you, Sharice, here. Please take the floor. What do you think is the best answer?
Um, I know in nursing we use different terminology, but when Dr. Williamson was going through the slides, I think I recalled that it was the motivational interviewing technique where you're trying to explore like the person's whatever the behavior is, you're trying to explore it with them and trying to figure out like where they want to be, not in a judgmental way, but trying to help them get to where they're going or what their goal is.
Right. That sounds like it.
Is the best answer. That's a really good
So
answer.
that's it.
That's a textbook answer. And not only is it a textbook answer, it's the correct answer. Based on your experience, that's a great way to break it down. You're just helping them model their behavior. You're helping them recognize the difference between where they are and where they want to be. So the next question is, what does roll with resistance mean? When we say roll with resistance. Go ahead, Michelle.
Don't argue. Say it seems like we have a difference of opinion. Let's move on to something else. But you don't want to ever argue with your client and say, I don't think that's right. And, you just have to like roll with it and move on.
Okay, so we have some answers here. So based on your answer, I want you to this is multiple choice, but that was really good too. So it's A, is it either A, arguing harder until the client gives in? Oh no, right? Is it B, ignoring the resistance? Is it C, adjusting your approach instead of confronting? Exploring ambivalence, which is exploring the patient's right to, to options and things like that? Or is it ending the session early?
It's C. I'm sorry, I didn't see the multiple choice.
Okay, I should have just said A, B, and C, D. Some of these are open-ended, some of these are actually multiple choice. So I'll give you the second chance. Do number 7. This is no right or wrong answer. This is open choice. And your answer was also correct too. It's C. And what does support with C was adjusting your approach instead of confronting, exploring the patient's ambivalence. So number 7, what does support self-efficacy mean? What does support self-efficacy mean? It's open-ended, no right or wrong answer. Anyone want to go and guess?
You promote their ability to grow and take care of themselves and take responsibility. Basically, affirmations. Oh, I'm sorry. Are there multiple choice again?
No, this is no right or
Oh,
wrong
okay.
answer. This is this is
Yeah,
us using our
basically
brains to just
support
decide.
their ability to take care of themselves and learn how to be responsible.
Okay, and how does that going to affect the patient?
Well, I think most of people who've been using or are in a bad place don't feel that they can do much of anything, and they don't feel that they are capable. And I think one of our jobs is to make sure that they feel capable and know they're capable and work with them so that they can rise up.
Okay, so the thing is, if I were to use one word to summarize it, is confidence, right? You want to help them boost their confidence,
Yes.
right? Okay, so you don't want to say things that will hurt their confidence. You want to encourage them, build them up, rather than break them down. Okay. Number 8. Now we're going to focus on OARS, ORS. What does OARS stand for? We kind of covered one of them. I'll give you the hint. The R in ORS is reflective listening. Does anyone recall any other ones besides reflective listening? So now you have to figure out, what does the S stand for? What does the A and the O stand for? So this is kind of like your dialogue, your consultation with the patient. So O is that's where you ask, like kind of what we're doing now, like a Q&A. We ask open-ended questions. That's the O. The A is, you can do it. I believe in you. Keep up the good work. Affirmations. Reflective listening. Oh, how does that make you feel? Ah, I understand. Okay. Okay, so is that a good or bad thing? What does that make? You're going to ask reflective questioning and mostly reflective listening, right? And then I kind of put a little bit of S in there, which is kind of summarizing. I kind of just summarized, Michelle, your whole thing about what you were saying. I said, oh, it's confidence. So you're summarizing, right? So we want to focus on being non-confrontational. So ORS is a great way to kind of like avoid all awkwardness and weirdness there. So number 9, which one is an open-ended question? So who can guess which open-ended question this is? Is it A, do you use drugs every day? Is that open-ended? Is B, have you ever been arrested? Is that open-ended? Is it C, tell me about your substance use? Is that open-ended? Or is it D, did you relapse yesterday? Which one's open-ended? Does anyone want to go? Harriet, anyone? Steve, Sharice, anyone want to raise their hand? Which one was more of an open-ended question?
It was C when when you were asking, tell me more. I love these kind of trainings, and I just been a little quiet. I don't want to jump in too much because it is very mirrors much of what we're taught in nursing. We just have different terminology, but
Yeah.
we use pretty much the same techniques.
Mm-hmm.
Yeah, so that's why I kind of just been trying to fall back a little bit because I'm coming in late and I don't know where everybody else.
No, you're doing phenomenal. And that's correct. It is C. Everyone's doing really good tonight. So that is correct. Tell me about your substance use. That's tell me, right? That's as you said. So that's the answer is C. Tell me about your substance use. That is an open-ended question. Number 10, what is the purpose of affirmations in MI? Open-ended question. So any answer is correct. No wrong answers here. Anyone want to contribute? Harriet, you haven't, no right or wrong answers here. What is the purpose of an affirmation? Harriet.
You recognize your truth, your strength. You recognize your strengths.
Correct. Very correct. That is the answer. And that is actually the best way. It helps you boost your confidence, recognize your strengths. Very good. Number 11, what is reflective listening? This is also an open-ended, no right or wrong. So what does it mean to you, reflective listening? Anyone want to go contribute? What does reflective listening mean to you?
Mirroring back what they've said, letting them know you've heard them and sometimes you ask a question like, did I get that right? Is that okay? Have I understood you? after you mirror back what they've said.
Yeah, that's very good use of reflecting, just repeating what they said from different perspectives or different ways of saying it. Very good. Number 12, why is summarizing important in MI? This is another open-ended, no right or wrongs. It's open to everyone's interpretation, and we'll build on it. Why is summarizing important? I guess I'll go. I think summarizing is important because it helps put everything in perspective. It helps you break things down systematically. So when you leave your session or you leave your meeting, or a person leaves you, they all have an understanding of what just went down. So just you collect your key points, and you just identify and highlight, ambivalence and change talk within recovery. So let's go to number 13. What are the 5 stages of change? Does anyone remember the 5 stages of change? You don't have to know them all, just any one that comes to mind. This is the point where you kind of look at the stages, and the behaviors and your role will influence whether or not they go back into or regress into one of the stages.
I can take a stab at it, but you'd have to correct the terminology because I'm not sure what the terminology would be. What I would think like
I don't want to get into trouble.
one of the changes, one of the stages would be in the beginning when maybe an individual is not interested in changing or is maybe a little ambivalent about changing. Whatever the behavior is that needs to be changed, maybe that will be one of the stages. I don't know what
Yes,
the terminology would be.
those actually fall within the first 2 stages.
Relapse, the second one would be relapse.
That's more towards the end. You want to prevent them from that happening. So that's where you would kind of use maintenance. So maintenance is the last one, but I'll start with, this answer to focus on what Cherise said, which was correct, was the earlier stages where a person's still using heavily, they have no interest in what you're saying. They might be like open to hearing you, but they're not really listening. You're just like, yeah, but I'm still going to take a hit, right? That's the contemplation stage and the pre-contemplation stage. So you have 4 stages. That pre-contemplation stage, they don't really care. They're just like using, it's part of their daily habit. What you're saying isn't really going over, or even they're not processing it really at all. But by you being there is great because they're there for them in case they relapse, right? Contemplation is like when you kind of have their ear, they know they're messing up a little bit, and they're kind of like starting to like understand, and you know what, maybe I should. You got a pamphlet or a card or someone you can refer me to or whatever, but they're not really taking it seriously. They're not really going to be taking any action on it. It's more of just like, I hear you. That's it though. Then you have the preparation stage, as Dr. Williamson covered. The preparation stage is, hey, man, maybe like this is messing up my family. This is messing things up for me personally or my job or whatever. Maybe I should start to take some action. So they're preparing. This is the preparation stage. This is send me what you got. I'm going to start to agree to maybe next week to stop using or whatever, or make a 30-day plan or New Year's resolution. Then there's the action stage. They're actually, cooperating with recovery. And then, but they still need a lot of support. Then there's the maintenance. You're doing things to help them. You're encouraging, you're using oars, you're reflecting, you're building them up. But you don't want them to relapse because, drugs are very, very addictive and very, very appealing to people who have previously used. So maintenance is like very important because you don't, as Cherise said, you don't want to go backwards by relapsing. You don't want to go back into that. It's like you're running a mile where you're just trying to reach a new mile or stepping stone in your progress. And then you constantly like fall back. So you've like actually like, in fact, went back to the starting line as opposed to maybe being 3 miles into recovery, right? So that's like the stages. You have pre-contemplation, contemplation, preparation, action, and then maintenance. So the question was, what are the 5 stages? Those are the 5 stages. Okay. Number 14, in which stage is the client not considering change? So when are they not hearing you at all? Is it the contemplation stage? Is it the preparation stage? Is it the pre-contemplation stage or is it the maintenance stage? Which one is it? Which one is they're most likely to just ignore you? Then we have 5 stages here: pre-contemplation, contemplation, action,
Relapse.
maintenance. Relapse is not one of the options. We have different stages. We have pre-contemplation, 1, contemplation, 2,
Contemplation.
preparation, 3, action, 4, maintenance, 5. So which one of those stages are they just not listening to any advice or any guidance? Which are they most likely to just ignore you because they're just so, that's their cycle. They're just going through their days.
Can you send me
Which one?
Michelle, go ahead.
Pre-contemplation.
That's correct. So as opposed to contemplation, they're not even, they're before that. So they're not, pre means before, right? So they're not even at the stage of processing any positive, like, maybe you should check yourself in, maybe you should do this. It's kind of like if I'm overweight, right? I'm enjoying my fast food. You're talking to me while I'm eating a cheeseburger. I'm not listening to you. Say, oh, maybe you should go vegan. Yeah, well, maybe you should just leave me alone and I can enjoy my cheeseburger. That's like the pre-contemplation stage. They're not really hearing anything you're saying because that cheeseburger is really good to them at that time. But as they realize, maybe they go through the later stages, they maybe get some blood work done, high blood pressure, whatever. They're thinking about life. They probably can keep up with their kids in the playground. They might be willing to listen to you. That's more moving towards the contemplation, the preparation, and action stages, right? Okay. So next question.
Did you get it yet?
What does a client in contemplation look like?
889.
31889.
This is open-ended. No right or wrong answers.
On your TV. I'm working. 231889.
So question, what does a client in contemplation look like? What do they look like?
See, I don't want to get in trouble because I want to learn the terminology here.
Listen, I'm giving you a pass, Steve. You've no right or wrong answers for
That's
this
why I've
question.
learned it. I just want to keep quiet and learn from you guys.
No, you have to
The trouble, you the wrong terminology.
So we're here.
I want to learn your guys' terminology.
It's fine.
Trouble.
This is an open-ended question. No right or wrong answer. Just consider how you might affect others based on what you're saying. That's all. Just be mindful of outdated verbology, right? So, what do you think a person who is using that's in contemplation, like they're hearing you now? What does that look like? Just take it as like, a person has an eating habit, for example, and they're finally listening to some dietary advice. What does that look like? Anyone? No right or wrongs.
They change their diet completely, or they they're making changes in their life.
Okay.
Yeah, they're making changes.
Do you think they're fully ready to 100% go cold turkey right away?
Not. It's a process for them. It's a slow process, but they're making,
Okay, so you think they might not be fully ready yet, but they're just still listening and hearing.
Yeah,
Okay.
listening, but it's a process, a slow process for them.
Okay, that's a fair answer. Anyone else? Go ahead, Michelle.
Ambivalent is a big feeling that they have, and they're not really ready, but they're starting to contemplate it.
Yeah, right. So what do you do when you're starting to contemplate, Harriet? On, like, for example, what you should be, you don't have to just apply it to substance use. We can apply it to other things in an analogy form. So you might be with someone saying, hey, I think you should do this. When someone's telling you or giving you advice, and you think it's hitting, now you're listening, you're feeling ambivalent, you're not ready yet, right? As they both said. What's going through, what's the thought process like? What do you think they're thinking?
It should be a decisional balance.
So they're like weighing things.
Yes.
Yeah.
Oh, okay, that's perfect. That's right on the money. So let's go to the next one. What does a client in preparation look like? No open, no right or wrongs. This is an open-ended. So you're in the action stage. So you passed the pre-contemplation, you passed the contemplation, you passed preparation. Now you're taking action on your behaviors. What does that look like to you? Do they still need a little bit of support?
Yeah.
That's fair. That's fair. Let's move on to the next one. What does maintenance focus on? So that last stage when where you are more of a risk, relapsing does more damage to your progress than in the earlier stages because you haven't made that decision yet in the earlier stages to commit to something. So what does that maintenance look like? What does it focus on? No right or wrongs, open-ended.
Repeat the question again.
What does maintenance, the last stage of change, focus on? You kind of keyed in on this earlier, Steve, but you didn't.
Prevention.
Relapsing.
Right. So you would want to prevent that, right?
Yeah, prevent relapsing.
Because it's like you're reaching the finish line and relapsing is going to take you right back to the start line. You don't have the will, you got to just commit, right? Okay. That is correct. Preventing relapse in the last stage.
Relapse. Right.
One of the main points of maintenance. Does anyone else want to focus on what does maintenance focus on or contribute to what does maintenance focus on?
Perfect.
So as opposed to support, you got to engage them, right?
Yes.
Sustaining change is the key. So 19, I guess, this is kind of like optional. You can stay, you can leave if you want to learn a little bit more.
Redirect.
So we're just going to go through, we got about 10 more questions. This is optional, and it's it's not a requirement. You can go home, you can close out and leave if you want tonight. I'm not keeping you guys here against your will. So 19, what is the best approach for a client in pre-contemplation? What is the best approach? So someone in that first stage, not hearing nothing what you're saying, they're still using, it's like their habit. They really don't care what you're saying. So what's the best approach for them in that stage to help them? Is it A, push them to admit that they have a problem? Is it B, building trust, exploring ambivalence, avoid pushing change? Is it C, giving them a strict relapse plan?
B,
because they really are paying attention to what you're doing and they're not, they're really paying attention at the time? Or is it D, make them sign a sobriety contract, make them do a hard commit?
B.
You think it's B? So what's
Yes.
B? Building trust, exploring ambivalence?
Yeah, continue to build
Getting too
trust with
pushy?
them, for them to be open up to you, of course. Yeah.
Right, because they're still getting high and they don't really care about what you're saying. So like I said, just being there for them, building the trust is very paramount in those stages because the more they trust you, the more you can help contribute.
Yeah, I just started to having the the recap of when I was working in the institution too. You have to give them, as I said, build trust with them for them to open up and tell you things what's going on. Yeah. So I'm just using what I remember in my training and in my experience working there. So it's building trust.
Now this one's no right or wrong, it's open-ended. What intervention is most helpful in contemplation? So let's say you're in the contemplation stage. So you've passed that stage that we just talked about. Now you're in the next stage. Now you're actually maybe listening a little bit more. You're realizing that this isn't a sustainable lifestyle, or it's just you just need to get better. So you're a little bit more open to suggestions, a little bit. Like you're still falling back into the contemplation, pre-contemplation, but you can still be open to intervention. So what intervention is most helpful in this moment?
Exploring ambivalence.
Okay. Okay. Do you think you can have a discussion with the individual at this time, or are they, you think you can have a conversation about what they're doing?
Yeah.
Yeah.
Yeah. Okay, that's fair. Okay, so before they start to,
You don't want to push it, but it's like just exploring like the ambivalence.
yeah, so as opposed to the next stage, when they're doing that on their own, they're weighing the pros and cons. Before they get to that stage, they're still like in like a contemplation, like you can talk to them to help them go into that preparation stage. So you can discuss the pros and the cons. You can start to mold the discussion at that stage.
Exactly. Yeah.
Okay, because they might still be having whatever they got going on.
Yeah.
But you can still open a dialogue and have them, you can push them gently into thinking about it on their own, not force them to do anything.
Right.
The next one, what intervention is most helpful in preparation? It's another open-ended, no right or wrongs. What's most helpful in the preparation, the next stage, the stage where they're actually thinking, planning, and all that?
Planning. I mean, that's really important. Yeah. Start
Anything
making
else?
courses.
So think of this as like a race, like a marathon. You got to run to your finish line. Your finish line's recovery, stability, abstinence, all that great stuff, right? So before you actually see it, the finish line, you have to set a plan on how to get there, right? So you set a goal. You set goals for yourself. So planning is a part of that. Setting a goal. You're not going to run the race by yourself. You got people by your side. You have resources. So that's where you can start to identify resources, right? Next one. What intervention is most helpful in the next stage, which is actually running the race, the action stage? What is most helpful for that? This starts to go into the things we're talking about, our behavioral models and all that good stuff. Anyone want to contribute? We kind of grab from that. So as opposed to planning, weighing pros and cons, you're actually out there doing the work. You're out there day by day, running the marathon. So people are going to face challenges, right? They're going to find moments where they might have to find an alternative source of coping, right? So that's what your role is there. Your role is there is to help them mold their behavior. So discussing strategies, self-talks, building up their confidence, small groups, things of that nature, finding incremental moments to reward their progress. That's how you motivate someone to reach that finish line, as opposed to going back to the starting line, right? And just monitor the barriers. Like, honestly, those barriers are important too. You don't want to get too close to the person, right? And in the sense to where you're going to hinder their progress, but you just want to be a supportive figure in their life, right?
Then some hope. That's
Right.
where the chaplain comes in, the chaplain work comes into.
Right. So next is so that was the very helpful for action. Okay. Next is what intervention is most helpful in maintenance? That last stage you were talking about where relapsing does the most damage. You're at the finish line, you're about to get there, but that relapse takes you right back to the starting. You haven't even ran yet now. You wasted all your progress. So what intervention is most helpful in the maintenance stage, the last stage?
Intervention.
Yes, intervention.
Yeah.
Prevention,
right.
all the shuns, all the TIONs, right?
Intervention.
Prevention.
Prevention.
Identifying the triggers, the moment. Yeah. What happened?
Yeah, prevention, yeah.
Very good. That's amazing. And of course, we talked about those resources because no one's running that race, that marathon on their own. They have resources. One of those resources are a support network. Okay. So let's go into the CBT framework. Does anyone know what CBT stands for? There's only one answer for this.
Behavioral therapy.
Congratulations, that is the correct answer. Cognitive behavioral therapy.
Mhm.
Okay. So the next question, let's move into what that is. CBT, cognitive behavioral therapy, is based on the idea that what three things are connected? What three things are connected? And obviously one of those is the acronym. So cognitive behavioral therapy states that what three things are connected?
Behavior,
Yes, behavior. There you
Yeah,
go.
behavior.
B.
Yeah.
That's the
thoughts,
B in CBT. So behavior is connected to what though? What is connected to behavior?
your thoughts.
There you
You
go.
change your thoughts, which changes your behavior.
Amen.
Yes. And so one last thing, when you see the commercial for that Junior Bacon Cheeseburger with the drizzle and all that stuff, how does that make you feel? It makes you feel, right? Feel something.
Yeah, you're
So
tempted. You're
CBT
tempted.
proposes that the behaviors, the thoughts are connected to what?
The behavior.
Thoughts,
Thoughts.
Well, we said that. So your thoughts are connected to your behaviors, but they're also connected to how you,
feel,
yes, how you feel. So thoughts, emotions, and behaviors are all connected. So the idea is that if you can adjust how people feel when they see these stimuli or are exposed to these things, and you can adjust how they think about it internally, they can then make the responsible decisions in recovery on their own, well, with your support. So what is the cognitive part of CBT? Does anyone know what the cognitive part of CBT is?
awareness,
Awareness to what?
your thoughts, behaviors.
Okay. So think about those, remember those stages, those 5 stages we talked about? So as they go through those stages, everyone's human. Someone might fall back in or whatever, or go to a party or something and be around those stimuli, right? So in a day-to-day person's life, you can't just wake up and forget you had these experiences. So to some degree, it's a challenge to run that race. So the cognitive part of CBT, by identifying these things, is stating that a person's thoughts, so helping them identify these thoughts, is really key in beating those challenges. So the next question is, what is the behavioral part of CBT? Does anyone know what the behavioral part of CBT is? So CBT proposes that your thoughts are tied to your emotions and your behaviors. So let's elaborate on the behavioral part. What does that mean, address?
The action. Let's see. Oh. Behavior.
Okay, I mean, you could remember that behavioral experiment we talked about, right? We talked about increasing positive activities, reducing avoidance, so dealing with the problem. Okay, so now we're going to do addiction treatment. So what is craving management in CBT? Craving management, you're craving that cheeseburger, that Big Mac, that steak, or that, or even that salad that has a nice dressing on it. What is a craving management in CBT? What's the first step to managing that emotion? What's the first step? No right or wrong answers.
Not to act
Finding
upon it.
Go ahead, Michelle, and then we'll go to Steve.
Sorry.
ahead.
Finding your triggers, practicing things that you can do when it comes up, role playing.
Okay, what would you propose, Steve? No right or wrong answers.
No, I was just saying not to give in. Fight the you're gonna fight the crave by maybe redirect yourself to something different. Could have been like something more healthier.
So
That's
I'll
what
put it
I-
to you like this. When you see a commercial for that, you just went out, you just ate out at that restaurant last night, now you see a commercial for it. You just worked out at that gym, now you see a commercial for it. You just went shopping at that store, now you see a commercial for it. You're going to be confronted with these things. The patients are going to have these moments where they're just,
Yeah,
instead of it
you're
being
gonna
a
be
commercial,
tempted.
it's them being in that same environment. It's them having
But you're going to
stress.
be tempted to yeah.
So stress is a big factor. That's that commercial that's going to push them into relapsing, right?
Yeah, relax.
So we adjust. So how do you manage that? How does one manage that?
By your thought and behavior.
Right. You develop coping strategies. You
Oh,
develop the
coping, yeah,
strategies how to
coping
cope, right? You
Yeah.
manage those thoughts. Remember the idea in this model is that your behavior is tied to your thoughts and your emotions. So you manage that. Okay. What is high risk situation planning? So the high risk situation planning. So someone who's like a high risk person, someone who's a bit, dangerous in that stage of their recovery. How do you manage that? What is the high risk? How do you plan for that? How does one who is a case act chaplain plan for those scenarios?
I guess that's the role playing and seeing your and making a plan for them.
Yeah, very good. Because you don't really plan. You more so empower. You empower them. So role playing is a great way to empower them, to build their confidence, to help them. So you can kind of anticipate, like saying that, for example, a patient tells you that their mom died on this day and it's getting close to that day. That might be a stressful moment for that person. So they're more prone to be more high risk during that time. So you don't really know, but you can prepare by helping build their confidence, doing the role playing, and anticipating those moments. So and we're going to close it out on here. We'll do 2 more or 3 more questions and we'll leave it for that. So one of the last questions we'll ask today is, I'll go to the end because we have harm reduction questions and we also have evidence-based harm reduction. Come again?
No, I was asking if the answer is going to be, you're going to have
I'll send the answers if you want me to send them. And we also have
so we
therapeutic
can,
boundaries.
like study material for us to study these answers.
No, I'm gonna send the link out next week. We're gonna have the recordings, the slides, and your content there to help you study.
I'm so sorry, but I have to go. I feel bad.
That's fine. That's fine.
But
Thank you for your
so
time,
much.
Michelle.
Thank you.
Okay, so the last question we'll close out with is, I'll go to the end. And the last questions I'll throw out there are, boundaries protect who? What do boundaries protect?
Protect us,
Who do they protect?
The case worker.
Okay, yes, and so they both protect the clients too, because we don't know who.
Client and the case worker, yeah.
Right, there we go. Very good. And one more, harm reduction requires abstinence, true or false?
Which one?
Harm reduction requires abstinence, true or false?
What's the first word?
Harm reduction.
Armory?
Harm reduction. So let's go into, I'll do one harm reduction question and then we'll go into, that's more of like the last thing. So we'll do first I'll just review. The 4 core principles of harm reduction are pragmatism, autonomy, humanism, and incremental progress. So harm reduction is more of the theoretical aspect of this, where you're kind of like helping them, accept them that, hey, it's okay. We're going to do these things to help you minimize your exposure to this. We want to respect your choices, and it's kind of like boosting their confidence, basically.
Okay.
So abstinence is good in other parts, but it's not the requirement for harm reduction, but it's still very important in peer-to-peer counseling, right? Or in client to patient counseling.
Okay.
Okay. So we'll go into one last question. This is a scenario, and it's one we just covered on CBT, cognitive behavioral therapy. The client says, I had a stressful day, so I had no choice. So the question is, what CBT skill would help? So the patient you're talking to says, hey, Steve, I just used today. I had no choice. What CBT skill and cognitive behavioral therapy would help. We just
Sure.
we let them just you let them go and keep using.
No.
What would you would you let it be, or would you address it?
I mean, I would try to get more information on what prompted it. So I think maybe I would go back to the open-ended questioning to kind of explore more of what happened and may have
Okay.
precipitated the
So what would be the
lapse.
goal in doing that? What's the goal by opening up those questions?
To try to help determine what caused it, because then maybe we can explore different tools or different things that could help the client to
Right.
explore different options on
Well,
how
Sharice, to
things
be
could
honest
be
with you,
done
if you
different in the
were to do
future.
that, you would be correct. You would be 100% correct, and because
Right.
you'd be identifying the thought process behind the cognitive behavioral
That's the
therapy.
word. Identify the thought process.
So that was a very good answer. That was correct.
Yeah.
So let's move into another last scenario for the night, and then we'll leave it be. The client says, "I know I should stop drinking, but it helps me sleep." My question to you both is, what stage are they in the 5 stages? So you remember you have pre-contemplation, contemplation, preparation, action, and maintenance. So when someone says, who's your client, says, "I know I should stop drinking, but it helps me sleep," what stage are they in?
Maintenance stage. That's my answer. Maintenance.
Try again.
I would say maybe contemplation, because they are identifying that it's a behavior that needs to stop, but they're
That is
explaining to
correct.
you why
That's
they're
correct.
doing
Yep.
it.
Mhm.
That is correct, because in contemplation, you can kind of have a real dialogue, more of a real dialogue with them. They could be more accountable, because now now they've been honest with you. Now you can start to push them into the action. So now you can say, "Steve, hey, I'm glad you told me that. I appreciate it that you trust me enough to tell me what's going on in your life.
Right.
Now we can start to to get you into treatment now."
Exactly.
It's the
Right.
action stage. That's when they start running the race, right?
Yeah.
Because you are their resource in this moment.
Right.
I think that's it for tonight. I don't want to overload everybody.
No, it was actually, you did an exceptional job, especially
Yeah,
for me
very
just coming
interesting.
in. Like, I think you did a phenomenal job at
Give him
helping
a
us
clap.
get to, yes.
He's a very
You're the
good
only
teacher. You
two.
deserve
Yes,
applause.
you're
Very
an
good. Yeah, we
you're
need
an
more.
excellent teacher.
Nigel, we want more of you, man. We want more.
Yes,
Of you. We learn a lot from you because you give
yes.
break down everything and you help us to understand and
Okay,
learn
so
more. You
so
should
that's what
come.
And
we'll
the
probably,
examples are really good, like,
Yeah,
tying in like an example that we can relate
I
to in
enjoy the
everyday
class,
life
Nigel.
okay, so
is a
that's what we're
way
gonna
to
do.
help us process it.
We're gonna have Diana do the and we'll do the Q&A at the end. But we'll do it so where it's not gonna be too much time on people. We might do like 10 to
Okay.
15
Okay.
questions. We might just maybe like
Okay.
10 questions and
Okay,
then
Nigel.
maybe 5
Did a good
scenarios.
job. Did a good job, man.
Yes.
Right.
I do
We
have one
learn.
question, Nigel.
Yeah, what's up?
I think it was Michelle, was her name. I
Yeah.
think she made a reference at one point when the slides were going, or maybe she may have just made a comment that she came from an abstinence program. Was
Yeah.
that meaning like there are some programs that don't meet the clients where they are and only support complete abstinence from substance use? Is that
In
what
my
she
ex-
was referring
well,
to?
in my experience, from my understanding, that field has changed drastically since its inception. So what might have been someone's experience a decade ago, or I don't know I don't know what anyone's situations are,
Right.
is might be different now.
Right,
You
because
know,
I don't think they do that anymore, right? I mean,
well,
they're not limiting you to completely stopping use of the substance in order to partake in the program.
yeah, so that's kind of like where Dr. Griffin understands with his treatment. He understands that he meets them where they are, and he knows that they might still be using, but
Right,
he leaves them. He builds the trust there. He leaves the door open so they can feel comfortable calling when they're about to use. So we get the
right,
real fix in there and get them taken care of really, really quickly
right,
before the
right,
drug dealer gets them, because the drug dealer is going to be that person that will be trying to take advantage of that person at the time.
right.
Yep. So you're right. And so what we're doing here is just getting everyone ready for the Stony Brook program. to where we'll be tested on what's happening now. So we
Yeah.
can go out
Okay.
into the city, we can go out into the streets and start to change lives, right?
Amen.
Right.
We are ready.
All right, so I wish
Yeah.
everybody a happy weekend. Hope everyone can still catch a little bit of that Super Bowl going on and the rest of the weekend with the kids and family.
Nigel, we want more of you, man. We want more of you.
Yeah, you did a
You did
really
great.
good
You did a
job.
good job.
It was
Trust-
very engaging as well.
yeah,
Very
that's what I'm
engaging.
saying. Yeah, Nigel.
Well, I
was,
appreciate it. You know, it means a lot. It means a lot coming from everybody. And, you know, you'll see more of me. We're going to be doing this all the way up until the end. Okay. So I'll see you next week.
Okay,
Okay.
perfect.
Okay,
Okay,
bye.
thank
bye.
you.
Take care.
Okay,
Bye-bye.
bye-bye.
Talk to you later, Sharice. Bye bye.
All right, sure.
Bye bye, Steve. See you later.
All right, nice. Yeah.